My name is Christopher J. Sparks, and this is the 26th of May, 2025. This is the Northampton State Hospital Oral History Project, and today I am joined by, say your name and spell it.
Michele Reiter, Michelereiter.
And we are in Michele's residence just outside of Northampton. So, to begin with the beginning, hospital health sledding, yes or no?
No.
Okay. Because it sets.
But I used to watch it.
There we go.
We used to, I was too afraid to do it, but I used to go and watch it. It was always fun.
Yep.
Yeah.
It tells us, did you come to Northampton for employment at the state hospital, or were you a resident in Northampton and thus was compelled to risk your life?
Right. Exactly.
On hospital health.
Right.
So how did you come to Northampton?
I was looking for a way out of New York City with my husband at the time.
Mm-hmm.
And I met a woman at my alma mater, which is Columbia University, who came from the Berkshires and said there's a position at Northampton State Hospital. And I had been looking around. We had sort of circled an area around, we wanted to be about 3 hours away from New York in a college town. We had some ideas of where we wanted to go. And she mentioned Northampton State Hospital. And the very next day, I called up and talked with the then director of social work, Marion Miller, and got an interview and drove up. We specifically came to Northampton for that interview. Mm-hmm. And by the time that day was over, I had had an extensive interview, had been at the hospital, been around, seen a lot of it. And my husband had spent the day in town in Northampton, loving it. And when I came out of the interview and I met up with him, he said, I hope you're getting this job because this is our town. This is where we want to live. And so that's how it happened. And we moved up here on June 19th in 1972. I was supposed to start work on July 1st, but there was a state hiring freeze. So I didn't start until September 1st of 72. However, we had a wonderful summer. We got to know the whole area, and we lived in West Chesterfield and had a really great time. Mm-hmm. So that was really perfect. And as I told you, when I got here, the first thing that I received was a list of 145 people who didn't need to be in the hospital. Mm. And we didn't have, many of them had been abandoned. I don't want to say abandoned, but their families had not been keeping up with them. But the hospital had not been keeping up with the families either. So one of the things that we did was we started contacting family members first to see if there was anybody. And it was surprising how many people there were who were willing to take an aunt or an uncle or a parent into their home who hadn't seen them sometimes in 20 years. I mean, there were people that we placed I'm 82, who were in my age bracket and had been at the hospital for 40, 50 years.
Yeah.
And it was their home. So getting people out of there, much of what was required was helping them to sort of reconnect with the idea of being part of a community. Yeah. Just the idea of going downtown and walking around would be, a major thing. So so that, Northampton State Hospital literally brought me to live here. Okay. And I've been here 53 years.
Wow. Tell me about that first day in the interview. What do you remember? What was your first sensation? What do you remember seeing or hearing or smelling?
Well, of course, it was in the main building, which had an enormous rotunda. When you first walked in, you walked down the hospital itself had some very beautiful, the building had some beautiful elements to it. There was a lot of, wood mahogany, and there was, these big windows everywhere. So it was very imposing. And when we first walked in to this big empty rotunda, several patients were kind of I want to say sort of meandering around. You know, they obviously had been, you know, walking. They had free access to the grounds. There were many, many people at that time who no longer needed locked care at all. So during the day, they were everywhere. They just walked around, and there wasn't that much for them to do. They used to have, I'm sure you know this, they used to have a farm and a canning room and a sewing room and a beautiful greenhouse. And so there were things for people to do. Even when I came, there still were some of those things. The farm was gone. Anything that had to do with the animals and the farm were all gone. And they weren't farming. They weren't, growing vegetables or anything anymore. There was still a sewing room. There was still a greenhouse. There were a few things like that, some occupational therapy kind of activities, and many people just wandering around doing nothing, smoking, chain smoking, which at that time they smoked in the buildings as much as they smoked outdoors. And I was a little scared. I was a little frightened, although I had been to many state hospitals in New York. But there was something about the ennui, the boredom of this wandering group of people they just looked like sort of blank-faced and, not in touch with the world. Not even, they could be looking right at you and you didn't have the feeling they were making eye contact.
I got it.
That kind of vapid, vacancy look in people's eyes. So I was a little bit frightened, and I was very excited by the mission because by then the Comprehensive Mental Health Bill had been passed in the Senate here in 89, I think it was, 69, I think. And so there was a mandate to reduce the population of the state hospitals. There was funding, finally.
Right.
So we could, they qualified, they were Medicaid qualified for what's called a level 4 rest home. It's the least amount of nursing care or, of skilled nursing and open setting. So not locked like you would find many nursing homes. And so we helped family members get people. We helped, when they worked on the farm, in the kitchen, wherever they worked, they received menial amounts of money.
Yeah.
And we had one woman the one who had been there the longest, had accumulated several $1,000s over a period of, who knows, it could have been 50 years that she worked there. So there was a guy that worked at the hospital who his opinion was that the patient's money should go to the hospital for their care. He completely didn't understand the concept of people receiving, remuneration for their work. But we prevailed, and we got them so that we could go and buy clothing for them to take with them. And because, at the state hospital, what would happen is people would drop their used clothing. Sometimes it was fine. And we had a clothing room, and the patients would go in and they would pick what they wanted to wear. But they weren't aware of how it would be if you go outside, in town. So you don't wear two different shoes, and you don't wear two different sets of socks, or, mismatched clothes. So we had to basically really teach them the most basic daily living skills and I don't know what to call it, just being out in the world.
Yeah.
So we would take them on excursions, small groups of them. We would go to the greenhouse at Smith, or we'd go to Forbes Library, or, we'd take a ride out to the Berkshires with 6 people and show them different places. And they would tell us stories about their childhood in the Berkshires and so forth.
Mm-hmm.
So that was the beginning.
Honestly, I can't even imagine the Berkshires in the 70s. Northampton itself underwent, such an interesting change beginning in the 70s um, to what it is today. So I simply can't imagine what the Berkshires were like.
Very, very conventional. A lot of poverty out in the Berkshires. There's a lot of wealth out in the Berkshires too, but it's surprisingly a lot of poverty poverty that most people who travel there in the summer and visit have no idea whatsoever
Right.
that's so. There was only one mental health center. It was in Pittsfield. Ultimately, they opened a center in North Adams and they opened a center in Great Barrington. So we had both North and South County each had their own mental health center eventually.
Mm-hmm.
Before the 80s, like by the late 70s, there were 3 mental health centers. So we could have them. There were psychiatrists. They could have their meds, and they could have therapy and group therapy. And they eventually opened a psych unit at Berkshire Medical Center, short term, like 14-day psych unit. So if somebody was having trouble, they didn't have to come back to the state hospital. They could go there.
Mm-hmm.
And usually it was something like they didn't take their meds correctly, or they needed a change in meds or something like that. So we got to become part of the Berkshire mental health system, Berkshire County. And in fact, my boss, the person who promoted me I was a clinical social work supervisor when I came, and within 3 years, I was a unit director.
Mm-hmm.
And I was promoted by the area director for Berkshire County. Each county had its own area director who directed the whole mental health system. And the point of the bill, Chapter 123, was specifically to develop a community mental health system.
Mm-hmm.
And that's what we were doing in all of the counties. And Berkshire County did very, very well, surprisingly, even though it was really, they were not sophisticated in any way whatsoever.
Mm-hmm.
And there were literally families that we met who vaguely knew about the relative in the state hospital.
Mm-hmm.
And it could be somebody like a grandparent or an uncle or even a sibling. And they literally didn't know about them. They were, hidden away, which I think was the point,
right.
So it was like an awakening, it was very, very exciting and satisfying and amazing what we did. We probably placed, from that unit alone, we probably placed close to 200 people over time.
Mm-hmm.
And even more later when we got to the point where we were actually developing halfway houses and residential houses for people,
right.
long-term houses. So that was very exciting. And as I said earlier, in 1975, we moved all of the patients out of the main building to various places. I can show you. I have a photograph on the wall of a memorial, and over time we closed each of those different places on Memorial except for G Building, and I became the director of the Holyoke, Chicopee, and Berkshire units.
Yeah.
Which was kind of like they had nothing to do with each other whatsoever. However, we kept on reconfiguring the space because we were shrinking the population so successfully that we had less and less need of space, and so that's how we went. And
so from 75 forward, your work was in Memorial Complex,
right,
rather than Old Main. Um, and that, I mean, that adventure sounds incredible. Tell me a little bit about your path to social work. Like,
Oh, okay. When I was a teenager, young teenager, 14, when I went to high school, I met people from a neighboring town I lived on Long Island, that had a community center.
mm-hmm.
And I started going to the community center, and it was integrated. It was an interracial center. And I met the staff were extraordinary people, including a man named Ben Luard, an African American man who took me under his wing. He just saw something in me, I think, and I saw something in him. And I joined something called the National Conference of Christians and Jews.
Mm-hmm.
And then we had a career day, and I met the dean of the School of Social Work at Delphi University. And he said, it's the job of a social worker to work herself out of a job. And I was maybe 15, but probably between 14 and 15. And I said, sign me on. That sounds like my career. And I never wavered from that time on. In fact, my mother was very upset with me that I kept on wanting to do these social activities, these political social activities. And so they sent a Jewish social worker to my house to talk to my parents, to tell them how wholesome it was and how much I, was doing that really mattered for a young person to be doing the things I was doing. My parents and I had a total disconnect about this. And when I got into Columbia University, my mother said, and I was already, by then I had worked in child welfare for quite a few years. My mother said, nice Jewish girls do not go into social work. They go into teaching so they can get married, have children, and then they have something to fall back on.
Mm-hmm.
And I said, well, then I guess I'm not a nice Jewish girl because that's not my path.
Yep.
And it was like that straight through the whole thing. I never wavered from it for 1 minute.
Mm-hmm.
And Ben was my mentor and my friend, and his wife was a professor at Columbia University, which is one of the connections I made so that I could get in there.
Mm-hmm.
And there it was. And as I told you earlier, because I worked as a case aide in the summertime at the child welfare office, and my job was to go out to the state hospitals on Long Island, of which there were 3 or 4 on the really far end of Long Island, and take kids from the children's units and put them in foster care.
Mm-hmm.
So that was my first exposure to state hospital was Creedmoor.
Right. That's incredible. Yeah, my maternal grandparents also Jewish from Poland.
Mm-hmm.
They immigrated after the war.
Mm-hmm.
And my mom went into nursing.
Mm-hmm.
And ended up at the VA for 30 years.
Mm.
So, but it was really stable employment.
Mm-hmm. Oh yeah,
that's what it is. So tell me a bit about what's your average day at Northampton State Hospital look like?
Okay. I developed an interdisciplinary team model that basically, and over time, through the consent decree, we were able to hire professional staff. So we had psychiatrists and psychologists and social workers, which were very sparse when I first got there. So we started the day with a team meeting, and it would last about an hour. And we would discuss anything that happened, whatever notes were taken the night before. We would hear about what happened overnight. We would plan the day, who was going where with whom, and what was going to happen,
Mm-hmm.
and talk about anybody who was particularly troublesome, who needed help. So we spent about an hour doing that, and it was everybody, nursing, social work, psychiatry, psychology, everybody was there. Prior to that happening, it was me and Mary Quinn sitting there going over with the nurses, going over, no doctor. And, when I first got there, the doctors were EFCMG, which I don't know what those initials stand for. That means that they were foreign trained physicians that were hired, and they had no psychiatric ability. Some of them did. The one that I worked with was I would consider him a very dangerous man, because all he wanted to do was sedate everybody. And he was a real big problem. And part of the problem was he did not want to participate in anything interdisciplinary. So after the initial, I'm already in D building. I'm not in the main building when I'm saying that we had the team meeting. It's already 75 by then. And then we would do rounds on each of the floors. We had 3 floors. The first floor was an open unit, co-ed. I got that. When we moved over there in 75, I made the whole thing co-ed. And it was the first co-ed unit in the state, and very controversial at the time. And people were sure that the patients were going to be having sexual contact with each other all the time. It was going to be like, Bacchus or something like that. It's so ridiculous. The ideas that people have of the lack of inhibition of mental patients, right? So we put them on levels of care that had to do with how much staffing they needed, how much treatment they needed, how regressed are they, how institutionalized are they, how ready are they to leave and move out into the community like that. Those were the criteria. And we did that without fanfare, without any problem whatsoever. So we would do rounds on each of the floors at that point, and check in. And a lot of times the rounds were about, when we did our team meeting, it was about people that we knew needed attention. What we would find is that when we did rounds, they were the docile patient, the withdrawn person, the catatonic person, the person who wasn't speaking. Those were the patients who would have been and had been very, very neglected in the past. And so we would purposely focus on what do we need to do for those people. So we also began to have OT people and other sort of recreational therapy, different sort. There were different titles, but they were all basically people who were developing programs, and we were helping them to figure out programs that were needed. We started doing group therapy. I was different from some of the other unit directors in that I'm a consummate clinician. I've always been a clinician ever since I was a little girl. So I wanted to do the therapy as much as I didn't want to be the director who sits in an office and, and makes dictums or whatever. So I ran group therapy. I saw several clients individually. I always had a caseload. I saw families quite a lot. So as we got further into deinstitutionalization, I spent a lot of time working with families, so we would do the rounds. We would, sort of identify individual patients who needed special attention and develop a treatment plan for them that worked. Ultimately, we were allowed to take over, and then the rest of my day, unfortunately, tended to be mostly in the Haskell building at meetings with the other administrators. And there were so many meetings. It was like you could spend easily half your day at meetings like that. It was really boring and a lot of times very unnecessary. And I found myself at times to be an antagonist because the other people, I didn't like what they were doing.
Mm-hmm.
And I wanted them to pay attention to what we were doing because our unit was considered the maverick unit,
Mm-hmm.
you know, because we were creative. I really think that that's why. So I managed to get the administration to give me a house that was just down the hill from D building where we were. And we made what we called a quarterway house. And we made it a house where all my OT people were down there every day, and a group of patients, 5 or 6 patients, would go down there, and they would cook their own meals, and they would, watch television. They would do whatever it was they wanted to do. They would do puzzles. They would go for walks. They would go downtown.
Mm-hmm.
They would go to the library, and they were in classes
Mm-hmm.
where they were taught basic social conventions, activities of daily living, and so forth. And so it got to the point where it was a very smooth transition from the unlocked first floor of D building to the quarterway house. They didn't sleep there. They came back at night to being placed. And that's how we placed them. And I had a dog, and my dog was wonderful dog, very docile, big dog. And we had patients. We had one patient who was mute, and he was terrified of any animal. He couldn't see a bird without freaking out. And my dog would sit outside my office on the first floor. It was right there on the unit with everybody. And we got to the point where we moved him closer and closer and closer to my dog until he was able to pet the dog. And, just like it was an amazing transformation to see how he came out of his shell by having this animal in the building. And then, of course, there were people in the administration who thought it wasn't a good idea to have an animal in the building and gave me a very hard time about it. And I happened to be lucky enough to have a deputy commissioner come down from Boston, a guy named Malamud, Dr. Malamud. And he thought it was marvelous that I had this dog. And he wrote me this wonderful letter, supporting me having the dog. And that was the end of the controversy, that I could have the dog, and it was no problem. And we saw him as a therapy dog, and he was doing that.
Yeah.
He'd go down to the quarterway house and be with people. It was amazing. And we were, then there would be probably at least 1, if not 2 days a week that we were driving to the Berkshires, because we were busy creating those group homes, and they were the level 4 nursing homes. It was yet to be actual mental health homes for, residential homes for people, or individual apartments or anything like that. This was before that. And we would go out and we would do training with the staff because they didn't know anything about psych.
Yeah.
And it was really, it wasn't complicated. It was really, just very, very basic stuff that had to do with dignity and, with, spending time getting to know the person, asking them questions so that they told you about their life, recognizing, acknowledging that they have mental challenges and helping them understand more about that, so forth. And we were very successful. By then I had hired a second person, a guy named Barry Nygrosh, who was a PhD. And Barry and Mary and I were the team that went out. And as I said, it was on average 1 or 2 days a week that we went. So that's pretty much what it was like. And we were constantly shrinking the population and the one thing those meetings really, the important part of those administrative meetings were that we were making decisions about how to reconfigure the space that we had.
Yeah.
At one point, we had to move out of, I think it was G building. We had to move out of a space because there was asbestos. So we had to move to a temporary location. We moved the whole entire unit in one day.
Mm-hmm.
And we were out of our much larger space that we really needed into this very small, terrible space, the AP building, for about 6 months while they corrected the asbestos.
Mm-hmm.
So, am I moving too fast? Because I want to.
Yeah.
In 1978, the Center for Public Representations, it was before they even really existed.
Mm-hmm.
Steve Schwartz came to the hospital. Barry and I knew him socially. And they began very small. They began being the lawyer for the patient when we went to commitment hearings. And the commitment hearings were held at the hospital.
Mm-hmm.
So for the first time ever, the patients had representation. And it changed the scenery quite a bit. And then over a very short period of time, maybe he showed up in 75 or 6. By 78, they had sued the Department of Mental Health, mm-hmm. Brewster v. Dukakis. And that, when they formed the consent decree, that changed everything. The day I was in an administrative meeting with all the area directors, all the unit directors, when they walked in and they handed us the suit. They literally, because all of the area directors were named as part of the suit, and they all handed us all the suit, and we all stood up and clapped. Mm. Because by then, the people that we had in the room were people who understood that we were moving in. If you're going to develop a community mental health system, you have to make services available to people in their hometown so mm-hmm. that they don't have to come to Northampton and be locked up in a mental hospital.
Yeah.
And so it was 69, I think, is when Chapter 123 was passed. It was 78 when the consent decree happened. So basically it was saying that the state was not in compliance with its own law.
Right.
And because you cannot sue a government entity for breaking its own law. Mm-hmm. There's no law that allows you to do that. So they had to go to the federal level, which is where they wound up with the consent decree. Mm-hmm. So it was a federal consent decree. And then we were able to, had a contract made with the University of Massachusetts Medical School, and they then provided the clinical staff, physicians, psychiatrists, social workers, psychologists, everybody. And we really developed an enormous number of people doing clinical work, helping patients to improve and placing them. Mm-hmm. And so that's, and we did that all the way through the late 70s all the way into the whole decade of the 80s was like that.
Right.
It was making sure that people who didn't need to be there, or, and of course we were always admitting people. So when we admitted people, instead of them just languishing, we had 24 hours. A team went in and met with the patient, and they developed a treatment plan, and that was what we were supposed to do. So some people were able to leave, if we had a 10-day paper, they would leave after 10 days, and we would direct them to the mental health center and get them an appointment, the appointments they needed. It was a total change.
Yeah.
Because we had the resources at that point. Mm-hmm. And it became a very, very, very necessary. In 1985, I became director of staff development. And the mandate from the state was to reorient every staff member, including ancillary staff, which meant groundskeepers, the security people, the people in the kitchen, everybody had to go through 2 weeks of orientation. It didn't matter if they worked there 50 years. They went to 2 weeks of orientation. And then we helped them to develop a plan for when they no longer had a job at the state hospital. What were they going to do? And we sent many of them to nursing schools. I mean, it was really an amazing effort to work with the staff who were very resistant, particularly people that had worked there a long time, and people that we called attendants, the mental health workers. We changed the name to mental health workers. Had no training, really, very little training. And so where were they going to go? Where were they going to work?
Right.
It's not like somebody like your mother or any other nurse. A nurse could find a job, but somebody with a high school education who's been working there since they're 18 years old.
Yeah.
Where are they going to go? So we started working with those people and developing courses for them. And I spent 5 years doing that before I was laid off. And we were the only hospital. The mandate was all through the state that every staff person was to be reoriented and then helped with some kind of at least discussion of what they were going to do when their hospital closed or when their job was eliminated. And we succeeded in 100%. In 5 years, we trained 100% of the staff at the state hospital. And everybody that came in, new staff that came in, they were there for 2 weeks. It was 2 weeks. And there was a combination of brand new staff and the older staff all mixed up. It didn't matter what department you came from. Just when your supervisor said you could go, that's when you went. And we were the only hospital that succeeded in that mission of 100%. It was terrific. The only thing that wasn't terrific is that at the end, in 1990, they decided, well, you've trained everybody. We don't need staff development anymore.
Oh.
So my own personal story with the Department of Mental Health is quite interesting, because I came and was put into a temporary social work position in 1972. I became a unit director in 1975. I was not given a salary upgrade. I was not, I had the title, but I didn't have the financial change in status. So I sued the Department of Mental Health for gender discrimination because there were two other unit directors, male unit directors, who were making a lot more than I was. And they settled that suit with me in 1981. It took 6 years. And I was put into another position that was out. Actually, it was a director of mental health clinic position from the Berkshires that was given to me. Also a temporary position. So I'd never had a permanent position at the state hospital ever in the whole 18 years that I was there. So in 1990, must have been 89. In 1989, they sent me back to work as a clinical social worker on the Springfield unit. And I know that they thought that they were insulting me because they would, in a sense, demoting me, although my salary remained the same, but I was being demoted into, working as a social worker, as a clinical social worker. I love being a clinical social worker, so I was perfectly fine with it. I had a ball. For about 8 months. I worked as a social worker and continued to do the kind of things that I love doing anyway, which is working with patients, working with family, helping staff to understand more what they were doing and so forth. And then in December of 1990, I was laid off. And I was laid off with 25,000 other state workers because it was right after Michael Dukakis lost his bid for the presidency of the United States. It turned out that rather than the state having an A plus bond rating, the state was in financial trouble. There had been a lot of mismanagement, and in '89 they laid off 25,000 people, and in 1990 they laid off 25,000 people. And they targeted people like myself I was 2 years from being vetted I would have been at something like a 68% retirement. I went down to 22%.
Wow.
Which is what I have. I have 22%. Thank heavens I had many years of working in other places that I have enough Social Security that I, get both state retirement and Social Security.
Right.
But that was an interesting way that they had to, not just myself by any means. I mean, they had a way of keeping people in those temporary positions so that they could do anything they wanted with you.
Right.
They could just pass you, along to somewhere else or get rid of you and do whatever they wanted. I even applied to, for other jobs in the category that I was in when they laid me off. And, directors of mental health clinics would say to me, "You're way overqualified for this. There's no way I'm hiring you to do this, because if I do, you'll take my job eventually." And I said, "I have no interest in your job. I would just like to work, and I'm a clinician, and I'm happy to work as a social work clinician and therapist." I'm 82 years old, and I'm still working as a therapist. I work virtually from home now.
That's great.
But I've never stopped. All through all those years that I was at the state hospital and since, I've always had a private practice. So, but they wouldn't hire me because I was overqualified, which of course I was, but it was all part of that whole catch-22. That's how the system works, and you find yourself, it's like a maze. You find yourself thinking that you're going in the right direction, and then you come on a wall.
Yeah.
And I eventually just gave up the idea of ever working for the Commonwealth again.
Yeah. Yeah. That's unfortunate, but that's the way it happens sometimes.
Yeah.
So you had mentioned the day that the consent decree came down, the papers were handed to the unit directors, and you stood up and you clapped. What's the atmosphere like at Northampton State Hospital at that point? It seems like it's going to close pretty soon. It kind of doesn't. It takes many years. It kind of drags. So tell me about how it was from, the change in atmosphere from people sort of meandering around listlessly when you arrive to, you've been actively attempting to close the state hospital, and it kind of seems like it's moving forward, if kind of, strangely, in a weird way.
It's a very good question. There was even when I first got there and we were placing patients one at a time, very small numbers, I think the census was 1,400 when I got to the hospital. There were always warring factions, I would call it. There were people who were on board, who were thrilled at the idea that we were going to place patients. David Brewster was a very good example of that. I don't know if you know David's story, but he was a really good example of somebody who, just didn't need to be there and had been there for way, way too long. But there were people who were threatened, staff, who were threatened by the idea that we were going to close the hospital and they'd be out of work. And I don't think that they were mean-spirited particularly. Some of them were. Many of them were just personally aware of their own limitations. They knew nothing. They didn't know how to take care of a mental patient or anybody properly. They were taught on the job. Some of them were really incompetent. We developed a system where, we worked with the unions. That was very complicated at times because, if you were management, the unions thought that you were against them.
Mm.
And I was management and I was not against them. I was for the unions. But I said, you cannot protect somebody who has just harmed a patient. And that's not what you're supposed to do as a union. You go ahead and represent him, but he's losing his job.
Right.
Because there were things that happened there where people should have been charged with assault and taken off to jail, in my opinion. So I was definitely one of the people from the very beginning who was identified as one of the people who was working toward closing the hospital. And some people loved that and some people hated that. And it was a very tense atmosphere. And it was one of the reasons why the reorientation was so important, was because we could talk to them, about humane ways of being with people who have mental challenges, and help them to understand what those people's rights were, and that we are not intending to infringe on your rights. However, the right of the patient, if you think about it as like a target, the bullseye is the patient, right? And so, and maybe the next level is the staff, but the bullseye is never not going to be the patient. So you are second fiddle, and it's an uncomfortable and scary position to be in. I can say that I was terrified when I lost my job there. It turned out I had a wonderful career after that. I'm happy to say that I was fortunate and I did really good work throughout my whole career. But I was afraid because for one, you get identified as somebody who worked at a mental hospital, and people immediately think of you as, I don't know, somebody not very bright or somebody who doesn't really care or whatever. And I would say 30% of the people, 40% of the people working there were really against it and really did not help. And they saw themselves losing. And so the tension was there, very, very much so.
Yeah.
And, I tend to be a fairly egalitarian person, but I was glad that I was a unit director, because I could say, you're going to do this or you're not going to do that. Don't ever do that again.
Yeah.
If I used to say to my staff, if you're doing something and I'm walking down the hall and you have to stop because I'm going to see it, you shouldn't be doing it.
Yeah.
It's a very simple rule, And so, but there were enough people, because now we had the clinical staff and we were hiring really smart young people dedicated to the field, people who really wanted to work with people with mental challenges. So it was improving. It was getting better and better all the time. There was even a point where we were sitting with architects designing a new hospital. And that was really exciting. I mean, we spent about 6 months. The state paid a fortune to this architecture firm from Worcester to design the perfect mental hospital. So it was very tense and at times really acrimonious. The unions, understandably and necessarily, fought very, very hard for their people, as they had to do. And so that, it settled down a little when we got to the point in '85 where we were going to retrain everybody and we were going to help people get to school, help them with their applications to nursing school, or wherever, find a job for somebody and make a suggestion that they, write a reference for them and make sure they get the job, that kind of thing. But it was definitely, after the consent decree came in, it was very, very tense.
Got it. Yeah, that definitely makes sense. The state hospital was, of course, a world unto itself, and you're seeing the end, right? It's a reality that has not existed for a century.
Exactly.
Northampton is changing pretty rapidly too.
Mm-hmm.
And if the state hospital goes away, the center of the economy is gone.
Yes, very much so. And there were things that happened. More and more patients were getting privileges to go downtown. As we were getting them ready to leave, we wanted them to become more comfortable with being in a community.
Yeah.
And a patient from my unit went downtown on a Saturday and started a small fire in an apartment building in Northampton on Main Street.
Mm-hmm.
And it was put out pretty quickly. It was almost not even an incident. A week later, she went down and she started a very, very serious fire using an incendiary. Mm. And we had no idea that this woman was, she was, I think, I might guess that she was terrified about leaving the state hospital. She wound up at Worcester State Hospital. I wouldn't be surprised if she's still there. She burned the building down and 2 people were killed. Do you remember that? You do, yeah. And it was just horrible. So there also was resistance from the town, from the community at that time, because there was definitely more of a presence of peculiar people, walking around downtown.
Mm-hmm. Yeah. Which brings us to the moment of, discussing dehospitalization and the limited programs and the limited funding available and the almost seemingly predetermined course to homelessness for a lot of the former clients of the state hospital. I mean, I've never spoken to anyone who had felt that made sense in any regard. It's just a matter of that's how it happened.
Mm-hmm.
But as the state hospital is getting closer to closing its doors, the problem is framed as a problem with homelessness downtown rather than a problem of, people not having anything.
Mm-hmm.
So can you talk about your experiences during that twilight just before the doors close and what you see and what you hear?
What I think I'm not opposed to hospitalization. I'm opposed to warehousing. Mm-hmm. And what we thought would happen was, and has to some extent, was that each hospital in the region would, and across the state, would develop a psych unit, a short-term, treatment-focused, literally when the patient comes in the first day, one of the first things that you're talking about is discharge. Mm-hmm. And where they're going to go and how they're going to be treated and how they're going to get the services that they need. In the 70s and 80s, we were rich with resources because of the consent decree. I mean, we had everything we needed. We could come up with a really peculiar plan that this person needs their own apartment and they need a job working at a florist shop. And we would create that, and we would find, that we could get that to happen. We could find the apartment, we could set them up, they would have a case manager, they would, there was a lot of services. Mm-hmm. And then it dried up, and it dried up before they actually physically closed the hospital. By 1990, it was already starting to be, because from 78, as you said, it took a long time, as it should have, because you needed all the resources and you have to create them. So, you're not going to just do it overnight. So by 93, when the last patient was leaving the hospital, there already was a serious problem with homelessness and people being hurt because they didn't have the services that they needed, or they didn't have the housing that they needed. And it, it's gotten, ever since then, it's just gotten worse and worse and worse.
Yeah.
I think Northampton is, is trying very hard to address the issue, and the churches have helped for sure. And there's been some sanctuary kind of stuff going on that's really good. I think the reality is, from a clinical point of view, from a point of view of a mental health advocate, the need for services has got to trump, excuse the expression, the financial issue. Massachusetts as a state is way ahead of many, many places in this country. And you see that we still have a long way to go. Like you're talking about Cutchin Center having, 12 beds for 6 to 12-year-olds. It's unbelievable. It's just such a small number. My next door neighbor worked at Cutchin's for 30 years.
In the whole state. The only program in the whole 12 beds in the Commonwealth.
Come on. Really. It's terrible. I know people that have worked in the children's units. There's now, they took over Providence Hospital, and, a private company took it over, and there's a children's unit there, I believe. I haven't actually seen that hospital since before it was an old, horrible looking place. They renovated it and did a lot of work there, and I understand that it's pretty good. But it has a very different mission, of course. It's not going to warehouse people, supposedly. It's not going to warehouse people. There will always be a need for some inpatient services, and that means there will always be a need for services that cost the most, because that's the most expensive way to treat people. And there will always be a need for it. I can't see, unless some wonder drug, I can't even, in my wildest utopian imagination, can't see how there will ever be enough to really treat the needs of all the people. And look at since the pandemic, kids are way more in trouble than they were before. The sheer numbers of kids, even relatively healthy kids that are, troubled with anxiety, with social anxiety, with depression, with learning disabilities, all kinds of things that we didn't anticipate. How were we supposed to know that was ever going to happen? Mm-hmm. So that has increased the need. And wouldn't it be nice if every time a need were increased and recognized and identified, which the Department of Mental Health does very well, that there would also then be the services development that would equal the number of need.
Yeah.
And that's just not happening. And so the critics, the people even who worked at the hospital, who were the critics of the whole thing, could very easily point to that. And they wouldn't be wrong. People living under a bridge in Northampton, it's just horrible. It's really horrible.
Yeah. Yeah, it is. There's a whole branch of my research called exile that is just.
Oh, yes.
Right. It's just what happens after. And I think that's an appropriate place to go now, which is, okay. So the doors are closed. There are services for some. It's not enough.
Right.
Talk to me about after the state hospital closes, and tell me, if there's one thing that we need to know, to remember about this whole adventure, what, in your perspective, would that be?
I have straddled both sides. I have maintained a very healthy professional relationship with the folks at Center for Public Representation. And at the same time, I really understand the fears and worries of people who worked there, and the I feel proud of the years that I worked there. I think we did a wonderful job. I think the majority of the people that worked there were amazing and did amazing, beautiful, wonderful work. And if anything comes out of this project or any project that has to do with the state hospital, I personally would want it to be to change the perception of what it was and of what we were doing and how we did it and how amazingly successful we were. Granted, there were things that went wrong, definitely, no question about it. And not because we weren't careful and thoughtful and intelligent and compassionate, but because things will go wrong anyway.
Right.
One of our patients went downtown. It's a very long story, but I could tell it. I would tell it off mic what his whole story was. But he went downtown after years of being at Bridgewater and then at Northampton, and he within a week went to Foster Farrar, bought a huge knife, and cut his throat. And he was living on Pleasant Street in a single room only place. And we were devastated. We had quite a few patients. I would say in the time that I was there in 18 years, maybe 8 patients that committed suicide. Two of them on the ground, one of them on the unit drowned himself, and another one hung herself at the abandoned main building. These are people I have never, ever forgotten.
Yeah.
They were given the finest of care that a person could have, with professional staff and paraprofessional staff who were quite smart and capable of helping them and taking care of them. And their illness was just beyond that. They weren't going to survive no matter what. And so I would really like to see the community of Northampton respect and honor the state hospital and the people who work there and the patients who were there. That's why that fountain and that sanctuary area that they've set up is so important. And that's why it meant so much to us, because it really is saying, the quote that's there, I can't quote it exactly. It was Anna Shukat's mother who said, that we need to honor the people who lived here and the people who worked here.
Yeah.
So that's what I would say. And I want there to be, moving forward, services that people need and better care for people that need care and need help. However, I don't want that to overshadow where we are now. Has nothing to do with what happened in 93 when we closed the doors. That's long gone. And so to blame it on the state hospital closing and to blame it on the people who worked diligently to make a community mental health system that was viable and that was going to work for people, we're defunding it all the time. So that's really, that's the current issue, not what happened at the state hospital.
Which, by extension, you could consider an issue of defunding as well, right?
For sure, definitely.
I know you may not be a fan of reading through the annual reports from the old state hospital.
I have one. Do you want to see it?
Oh, I'd love to. But
turn around behind you, just right on that shelf there, on the far right, is a very thick volume.
Oh, wow. Yeah. I have the PDFs of that. That's fascinating.
That's one of the originals. I had it rebound.
I was about to say I've never seen it bound thusly.
Yeah, I had it rebound, which probably destroyed its value, but I didn't care because it was falling apart.
Yeah, values. In the second year that the state hospital was in operation, in the year that it opened, so 1856 construction starts and it opens its doors in 1858. I believe it's the first, maybe it's the second year, but it's right up there. Dr. Prince is still superintendent.
Mm-hmm.
And the state changed the way that it compensated the state hospital. It said, we're going to give you, it had a fee for paupers, as they were called, that they were going to lower that fee. And they said, actually, you know, your salary has been coming out of the state budget in Boston, and now it's going to come out of the state hospital's central budget.
Mm.
And those two things start that ball rolling,
Mm-hmm.
which is more patients to be able to fund the staff. Of
course, yes.
Too many patients to treat effectively.
Mm-hmm.
So, and the story goes, you know, that stayed consistent one way or the other, the defunding of care throughout its entire existence. That is essentially the framework of its story.
Mm-hmm. Yeah, I just read an article yesterday about Bridgewater, mm-hmm. and that and I was shocked, to be honest with you, that Bridgewater State Hospital is under the auspices of the Department of Corrections.
Yeah.
And and we were talking about this in the 70s. They are just now talking, I'm sure they've been talking all these years, but it sounds like corrections and mental health are coming together to finally put Bridgewater State Hospital under the auspices of the Department of Mental Health so that they can do some treatment and it's unbelievable.
So there's no, it makes sense, and I think that I kind of knew that it was under the Department of Corrections, but I didn't understand like the implication, which is
it's
like the standards of state hospital you would expect from DMH. In fact, there's another level.
Believe me, I've been there numerous times. It's unbelievably macabre. It really is. It's just what a place that is. And we used to take patients from there. We'd bring them back here, and most of them successfully.
Yeah.
It's just like when they closed Belchertown.
Yeah.
I can't remember what year that was, but it was before I got here. It could have been 1970. They took people in buses and brought them to Northampton State Hospital and diagnosed them mild mental retardation and other unspecified conditions, and kept them when I got there, there were hundreds of people from Belchertown.
Mm-hmm.
And it was because the Friends of Belchertown actually rallied to close that hospital. Eventually, what happened at Northampton, I helped to start the NAMI groups mm-hmm. in Western Mass, particularly around here and in Holyoke and in Pittsfield. And eventually, the parents decided that they wanted to have oversight at the state hospital. And so we developed, I actually wrote an article that was published, I can't remember where, but we developed parents, what did we call them? They were like a watchdog group. They came in to units and they went through and they noted things that they saw that they didn't think were good. And they wrote them down and went to area directors and said, you have to correct this, you have to correct. And they did things like state hospital workers suddenly had to wear badges with their name on it. Mm-hmm. Oh, what a wonderful thing. Here's this group of people, they're already, in some other world and they have no idea whom you are.
Right.
No idea. You could be the janitor. They have no idea who you are. Now everybody, every staff member, we had a machine, we made them. The badges. They had to wear the badges.
Yeah.
And so everybody was identified. And there were staff that didn't like that. They were the ones who questioned the asbestos issue in G Building and got us an asbestos removal project.
Mm-hmm.
It was the parents that did that. It was the volunteers that did that.
Wow.
There were amazing things that happened because of them. And in places like Bridgewater, you haven't got a group of people like that. Belchertown had it, and eventually Northampton State Hospital had it.
Right. Incredible.
Very, very powerful and impactful.
Yeah. And not terribly difficult for some of those suggestions.
Like no, not many of them. Many of them, stop smoking in the building.
Right.
Perfect example. Put up curtains.
Yeah.
Lovely example.
Yeah. Things
that were just very, very basic.
Yeah.
Just, this is my son, this is my daughter. They have to live here while they're suffering from this terrible disease. And I want them to be comfortable and safe.
Yeah.
Very basic.
That's incredible. So we've covered some history. Is there anything that we haven't covered that you'd like to mention?
No, I don't think so. I mean, I think my emphasis, as I told you from the beginning, was coming to work myself out of a job.
Yeah.
Right? That was an old mission in life. And I pictured myself with the key in the lock on the last day. And I didn't get to do that because it was 3 years earlier that they said bye-bye to me, which was a shock to me. I thought I was indispensable. So, but I said at one point, and there might even be a pamphlet or a booklet or something where I'm quoted as saying, among the greatest successes of my professional career is contributing to the closing of Northampton State Hospital. Mm. And I still feel that way, in spite of the fact that there are all these issues that we talked about that are definitely problems and definitely need to be addressed. Yeah. But I still feel that way because, the consent decree said people are entitled to be treated in the least restrictive alternative possible. Yeah. And I think that's exactly it. And there are many, many ways to do that. And residential care is among the most important. Treatment like Cutchin's is among the most important. Because if you can work with those kids and help them at their age, they will not be the mental patients of the future. And if you don't, they will. And the population of people who are neglected will grow into a population of people you no longer can neglect. Yeah. And that's it. So, that's it.
Great. Thank you so much.
You're very welcome.